Good morning, and welcome to our very early Riser Symposium on the importance of personalized approach and risk stratification for patients with differentiated thyroid cancer. In the last few years, we've had an increasing emphasis on risk stratification, thinking about it longitudinally during the long-term follow-up of our patients. Today, we're going to really focus on it in some of the early management points. These are my personal conflicts of interest or dualities. So what is risk stratification? What are we really talking about? It's something that we as providers, as physicians, do constantly in the management of our patients. And talking about it in generalities, whether we're talking about cardiac disease or oncologic disease, we're talking about allowing us to prognosticate, to try to predict the future, as hazardous as that might be, of the likelihood of certain events occurring. And if we're talking about patients with thyroid cancer or any other form of malignancy, we're talking about what's the risk that a patient has residual cancer after they've had certain treatments? What's their chance that it might come back and might require some further intervention? Or in its most formal context, when we talk about cancer staging, what is the risk for mortality or death? Now, this is very important, and we learned in medical school the role of risk stratification in how we interpret things like laboratory test results or imaging test results. Risk stratification is just another phrase for figuring out the pretest probability. Let's not forget Bayes' theorem. We interpret tests in part based on context, the likelihood that this outcome might be predicted by the test. If we see something that makes no sense, we question it because it seems so unlikely for this patient. Okay, so we're constantly using risk stratification in our clinical management. And we use it to facilitate treatment decisions. And when we do that, we assume that we have all the right information, that we have the appropriate data to accurately risk stratify, or we have to fill in the gaps. We have to make some assumptions about what may or may not be true about the patient, which means that we also have to have some understanding of how good is the information that we have available at that point in time. Recognizing, as I'll show later, that that point in time is constantly changing. We're always adding and changing the information base. Finally, risk stratification, disease staging, etc., provides us with some standard language. We can say, we now know this is stage 1, and we have some concept of what that means, or ATA intermediate risk. We have some concept of what that's telling us. It gives us a common language that we can use. But risk is a moving target. Dr. Tuttle describes it as it's dynamic, right? But it begins from the very beginning when we first suspect or make a diagnosis. And so for thyroid cancer, when that patient walks in and we size them up, we look at their age, or we guess at their age, right? We feel the nodule, or we look at the ultrasound. We're already beginning to risk stratify just from that first few pieces of information. And we're going to make decisions about surgery with perhaps incomplete information about that patient's true risk stratification. Then they're going to go to surgery, or maybe not, but let's assume that there's more information that's obtained, and we're going to find out, oh yes, the ultrasound said that there was one suspicious lymph node, but the surgeon finds invasive disease wrapped around the recurrent nerve. So we add more data to our risk stratification based on the surgical findings. And then the pathology information is critical, because that's going to give us some gold standard, some pieces of truth, we believe. But even there's some variability. And we know that there will be differences of opinion. We get second and third opinions. So our assessment of risk is constantly changing. We add postoperative data. We may get a blood test, a marker level. We may add further imaging data to refine our ability to risk stratify. And then finally, we keep adding incremental follow-up data. So risk is a moving target. And how we assess it and how we manage it varies on our context as well. Because we can assume up here on this platform, thyroglobulin assays that go down to 10 to the minus fifth nanogram per milliliter, or tremendous capability at ultrasound that can reveal lesions that others can't see. But we all have access to varying levels of quality, or we may have no control over where the pathology specimen is interpreted, or what laboratory is picked for the thyroglobulin assay. So we all have varying capabilities of being able to assess risk accurately and ideally. Now, of course, the disease, thyroid cancer, is now considered a relatively common disease, but the amount of deaths due to thyroid cancer is a very low amount relative to the total incidence. So we just start out with an a priori that most patients walking in with a new diagnosis of thyroid cancer are at low risk for dying from the disease. But then we have to dig down, because the reality is that there are clearly those who are at much higher risk, and we can't apply that assumption to everybody off the board. We have a lot of disagreement, in fact, about this assumption that everybody on average is low risk. This has been changing over time. The disease that we're talking about now, or today, is different than your grandfather's thyroid cancer. Look at how the incidence of the disease has risen. We know this to be common now, but the mortality in general is considered to be flat, so that the average risk, just a priori, is going down over time. And this has led, in many peer-reviewed journals such as these, to this assumption that we have an epidemic of overdiagnosis of thyroid cancer, and beginning to paint a very broad brush, in fact, that, well, this is a disease that we're over-treating, over-diagnosing, and applying that to every patient is quite incorrect. It's not appropriate risk stratification. We have to personalize it. This is a worldwide phenomenon. In just about any country that you look at, the incidence of thyroid cancer is rapidly and steadily rising over the last 30 or 40 years. But this is not completely agreed upon. And there are other analyses of data that are suggesting, yes, the incidence rate is clearly increasing, but as you look at a lot of important subgroups of the disease, in fact, the risk for death is climbing as well. So again, we have to step back and say we can't paint with a broad brush. We have to individualize our assessment of risk. And we can start with things like, well, what's the actual histology? Why is the pathology so important? Well, even within the broad world of papillary thyroid cancer, there are different subgroups of disease, and we know that patients with tall cell variant of papillary cancer overall are going to have a higher recurrence risk. They're going to have a higher mortality risk. Those with follicular variant are going to have a relatively lower risk for these things. As I said before, our ability to apply this model also depends on our context. And it depends upon what resources, what skill sets, what laboratory specialties, et cetera, are available to us at any given time. What imaging capabilities we have will affect our ability to make decisions about risk assessment and how to manage it. Finally, how we interpret risk varies amongst us as well. You can keep the patient as a constant, but each of us in the room are going to interpret things a little differently. And so we have data from Haymart looking at examples of patients with different forms of papillary thyroid cancer fitting into a low risk for mortality, but the decision about how to manage those patients quite variable. And seeing institutions where the decision to give radioactive iodine might only be 5% of patients like that who present, and others where it's 95% are going to get radioactive iodine. So there's even individualization of how we as providers make the decisions about risk. And what we use to interpret that in a second study, physicians' anxiety about the patient's risk for mortality, separate from the actual quantitative data, influencing our decision making. So we're really personalizing this not just on patient characteristics, but provider characteristics as well. So we're going to talk today about a very key point in the ATA guidelines, the famous recommendation 50. And just to set the stage for our speakers, to remind us the different components of recommendation 50, that postoperative disease status, the presence or absence of residual disease, should be considered in making decisions about further therapy. Postoperative thyroglobulin levels, either on therapy or with TSH stimulation, can help to assess the persistence, help us about understanding whether there's residual disease or remnant, and perhaps help us predict future recurrence risk. That the actual optimal cutoff for using that thyroglobulin level is not clearly known, so we have to sort of use a gestalt interpretation. And then finally, that postoperative imaging studies, such as diagnostic radioactive iodine scans, perhaps with tomographic assistance from SPECT, or the use of other imaging modalities, might be very helpful in that postoperative stage, thinking about what is the risk and how do we manage it. So in summary, understanding risk is central to what we do as physicians, and it's critical that we apply it properly to clinical management. Risk assessment has to be individualized because each patient and each scenario that we practice in is quite different. And so we have structural as well as clinical constraints. We have to be cognizant of our own underlying biases as we interpret data about patients. And our tools to assess risk, the accuracy of our imaging, the accuracy of our laboratory studies, and the kinds of information and skill sets that we bring to bear change over time as well.